Good evening. Welcome to IBD Insider, patient updates from the 2026 Crohn's and Colitis Congress. My name is Victoria Tyler. I'm a social media ambassador with the Crohn's and Colitis Foundation. I'm also a social media influencer. I've amassed over 600,000 followers, and I use my platform to advocate and educate others about inflammatory bowel disease and life with an ileostomy.
Hi, and my name is Ian Goldstein, and I am also a social media ambassador for the Crohn's and Colitis Foundation. I've had Crohn's disease for about 20 years, and over the years, I've tried to turn it into, things that relate, just trying to relate to people. I put on comedy shows. I put on a show called The Autoimmune Saloon. So things that try to make light of IBD, which can be tough. So last month, the Crohn's and Colitis Foundation and the American Gastroenterological Association hosted the annual Crohn's and Colitis Congress, the premier meeting for IBD, and nearly 1,440 IBD health professionals and researchers came together to discuss the latest research about Crohn's disease and ulcerative colitis. Tonight, we are taking the information presented at the Congress and bringing it to you during IBD Insider so that you have the most up-to-date understanding of your disease.
Ian and I were both patient reporters at Congress, and we are excited to share with you our key learnings from Congress, and then you'll hear presentations from some of our expert clinicians about their highlights from Congress, including the latest in diagnostics and IBD medications.
Here are a few things to keep in mind. The information shared is meant to be for educational purposes only and should not replace any advice or guidance from your own healthcare professional. The program will be recorded and posted on the My IBD Learning virtual library. And everyone who registered for the program will receive a link with the recording next week.
We want this to be as interactive and engaging for you, so we encourage you to submit your questions through the Q&A box, which can be found at the lower part of your screen. Following our expert presentations, I will moderate a Q&A session with all of our panelists and will address as many questions as we can at the time. On behalf of the Crohn's and Colitis Foundation and the American Gastroenterological Association, thank you all for joining. We're going to kick this right off and we're going to jump into some of the things that I had an opportunity to learn at Congress. Creeping fat. What is it? What it does? And what's next? Creeping mesenteric fat is fat that wraps around inflamed intestines in Crohn's disease. Research presented at Congress shows it is associated with fibrosis and intestinal strictures. Fat wrapping is linked to mucosal inflammation and disease progression. Experimental models suggest creeping fat may actively drive inflammation, not just respond to it. Researchers are exploring creeping fat as a potential future therapeutic target. Creeping fat is an active player in Crohn's disease biology and may shape future treatments. One of the really exciting presentations I had an opportunity to enjoy was amplifying the patient voice and perspective. Voices are increasingly shaping research priorities and care models. Advocates like Tia Aswani and patient contributors help develop tools like the AGA IBD Drug Guide. The Crohn's and Colitis Foundation has an IBD medication guide that patients can easily access. Including patient experience improves shared decision making. Patient perspectives help clinicians better understand quality of life changes. Representation ensures care reflects real patient needs. Patients are essential partners in shaping the future of IBD care. Perianal fistulas and the impact on the quality of life. Perianal fistulas are abnormal tunnels that can occur in Crohn's disease. Symptoms may include pain, drainage, infection, and discomfort. Significant impact on mental health, daily function, and quality of life as a result of perianal fissures. Multidisciplinary care and new therapies are improving management. Treating fistulas requires both medical innovation and holistic patient support.
Great. Thank you, Victoria. That was great. So I'm just gonna present on my the things that I took from the Congress that we attended as well. So one of the first things I covered was stricturing medication and strictures, which is a very personal thing for me. I've had Crohn's disease for about 20 years, as I mentioned, and throughout it, when I've been inflamed, the inflammation usually turns to strictures. And if you don't know what stricturing is already, it's stricture. A stricture is a narrowing of a portion of the intestine. And for me, that meant the strictures eventually led to like bowel obstructions and ER visits and eventually surgery. So I was always told my whole life there's never going to be medication for it. So this was particularly interesting. What the doctors talked about during the presentation was that what they're learning is bacteria migrates across the lining of the intestinal tract and can trigger what Victoria was talking about, which is creeping fat, which surrounds the intestinal tract. And then this bacteria and creeping fat might actually be the key to how to treat strictures going forward. And it's amazing because my whole life I was told this is a mechanical issue that only has a mechanical solution with which is surgery. So to hear that there might be medication that could help prevent stricturing would be amazing. And what they talked about too was that it may not just prevent fibrosis or narrowing, but it also might reverse it depending on how advanced it is. If it's super advanced, it might not be possible. So yeah, I was very excited for the stricturing medication portion of it. So the next portion that I talked about was just health insurance. I'm sure any of you watching, we've all encountered many issues with health insurance in some form, denials, and I was particularly fascinated by this presentation given by a clinical pharmacist named Melissa Kirkpatrick, who she was basically telling us, a reminder to patients and doctors to work together to make sure that medications are approved. I'm on a dual biologic myself for Crohn's, and very often health insurance will reject one and approve the other because they're like, you only need one, but that's not usually the case for me. I need both. So what she said is that, when a medication is denied or when a prior authorization is needed, it's going to delay healthy outcomes for patients. That's never good. We're trying, hopefully, speeding up that process if possible. And one of the key things that she talked about was this idea of beforehand, clinicians should expect a denial in some form. How to anticipate a denial. So common reasons for a denial is something like my case, which is a dual biologic therapy or an escalation in dosage. And it was just really important to know this, I think, as a patient and a clinician, so you can work together if any medication you need is not approved. And then the final thing that was really interesting to me was from a patient advocate named Tina Aswani Amprakash, and then a GI psychologist named Megan Reel, who's also a Crohn's Colitis Foundation trustee. They were just talking about the psychological impact of periodontal Crohn's disease, but they also talked about trauma-informed care and how important it is for a doctor to have a good relationship with a patient. It was empowering to see a patient and clinician appear on stage together. They highlighted how crucial it was that a clinician and patient work together. I've had providers who truly listen and were patient with me, and others who rush out of the room. So and they don't really leave room for questions. So it's really important. And one of the quotes that I really liked that Tina said was, this IBD can rip the life out of us, rip the life out of us. So it's extremely important for doctors to be aware of that and take that into consideration before they rush us out. And they said trauma-informed care is not a checklist. It needs to be a collaboration between patients and doctors. So really loved what they presented there. Um, so I hope everyone on the call today found our perspectives helpful. At this time, I'd like to introduce our first featured expert, Dr. Noah Krugliak Cleveland. Dr. Krugliak Cleveland is a gastroenterologist and assistant professor of medicine in the section of gastroenterology, hepatology, and nutrition at the University of Chicago. She's an expert in inflammatory bowel disease and serves as director of the intestinal ultrasound program at the University of Chicago. Dr. Krugliak Cleveland is a recognized leader in the dissemination of intestinal ultrasound across North America and is the co-founder and president of the Intestinal Ultrasound Group of the United States and Canada. Her research focuses on the application of novel technologies to improve detection, monitoring, and prevention of complications in IBD, with particular emphasis on ulcerative colitis as a progressive and transmural disease. Dr. Cleveland will now be presenting on intestinal ultrasounds for IBD.
Thank you for the introduction, Ian. And thank you for the Crohn's and Colitis Foundation for inviting me. So I have the pleasure to present to you today on intestinal ultrasound for IBD. Here are my disclosures. So before we talk about intestinal ultrasound, I want to give you a little bit of background about the progress we've made in inflammatory bowel disease care. We've really moved away from crisis management, reactive management to proactive management. But getting to this point required a lot of progress, and that's from developing effective treatments to learning that symptoms are not really reliable and do not really well correlate with disease activity. We also had to recognize that we need monitoring tools and develop those tools, and then evidence that those tools, those monitoring tools actually improve outcomes. And then lastly, we wanted to prove that we actually can change a disease course by doing all these proactive management. But with all this progression, there's still a lot of unmet needs in inflammatory bowel disease. There's still no cure. The disease is still progressive. Diseases are still progressive. There are still complications that occur. And as many of you are aware, there's limited therapeutic efficacy to many of our treatments. And with that, there's also a lot of limitations to our monitoring capabilities. So on the right, you could see a list of the common monitoring tools that we use in inflammatory bowel disease, with colonoscopy being the gold standard, meaning that's the mainstream assessment and what we consider to be the final determinant of whether there is disease activity or not. C-reactive protein, which is a serum-based test that we assess for inflammation. Stool calprotectin, which is a test that assesses for bowel inflammation using stool collection, and then there are radiographic studies such as CT and MRI. With those tools, there are a lot of limitations and challenges. So endoscopy is the gold standard that requires sedation. There's also some delay in scheduling, and you can imagine that it can't be repeated that frequently. The other radiographic studies, such as CT, requires radiation exposure, so it's very difficult on patients who need to undergo multiple CTs over their lifetime with cumulative concern for cumulative radiation. The pediatric populations struggle both with endoscopy and radiation exposure. Women who are pregnant cannot undergo these tests. There are also both CT and MR require ingestion of contrast, which is incredibly difficult, especially in patients who have stricturing disease or narrowing of their intestine. And the machine scanning may not be well tolerated, especially the MRIs, which could be very lengthy. Stool collection is quite a challenge. You have to come pick up a stool collection, then go and do that at home and bring it back, and it leads to lack of follow-up often. And lastly, all these monitoring tools are just not consistently used, and they all have some delay associated with them, as none of them are done in and during your clinic visit. So intestinal ultrasound really fulfills a lot of checks really all of these boxes and has many advantages. You could see that as I'll present to you today, it's a non-invasive test that requires no bowel preparation, contrast, or fasting. It is the only real-time the only tool that gives a real-time assessment of disease activity. It is incredibly accurate. It is reproducible and repeatable, and it can detect treatment response incredibly early. Additionally, it's very sensitive to also detecting early signs of relapse. So intestinal ultrasound, you could see here on the video, is a test that ideally should be done in the clinic visit. It is an examination done by scanning the abdominal wall to visualize the bowel. We use sound waves to produce a 2D image, and by that we assess for inflammation of the colon and the large and small intestine. We traditionally use it in ulcerative colitis and Crohn's disease, but it could be used in other inflammatory conditions of the bowel. It is, as I mentioned, the one and only test we currently have that can produce real-time results during your clinic visit. When on a number of studies uh, surveying patients on the tolerability of this test and the preference of patients, you could see that intestinal ultrasound is not only well tolerated but preferred over all the other monitoring tools that we have, including colonoscopies, flexible sigmoidoscopy, stool sampling, and even blood sampling. In addition, patients found that intestinal ultrasound enhances their knowledge of intestinal ultrasound, excuse me, of their disease, and it allows them to participate in shared decision making. So, as I mentioned, endoscopy is still a gold standard, meaning that that's currently what we look for when we compare other monitoring tools. And when you compare intestinal ultrasound to stool testing or even patient symptoms, you could see that intestinal ultrasound predicts and the endoscopic findings better than all the other tools. So what does this mean? It means that if I do intestinal ultrasound, I find a certain degree of inflammation and describe where it is and the degree of it, there is no need to repeat an endoscopy typically, as this typically will correlate with endoscopy and it will correlate well. So what do we look for in intestinal ultrasound? The one and most important parameter is bowel wall thickness. So at the bottom left, you could see an inflamed bowel. I typically describe it as a sausage cut the long way. And when we see inflammation, the bowel wall, which is depicted in a yellow arrow here, and I'm pointing with my pointer, that anterior wall of the bowel should be 3 millimeters or less in an adult or 2.5 millimeters or less in children. And if that thickens to be greater than that, it's a sign of inflammation. And you can see in comparison on the right, a normal bowel that is healthy is quite thinner. And what I often like to describe the bowel as an Oreo cookie of a black, white, and black layer on ultrasound. You see that that double stuffed Oreo cookie here in the inflamed bowel looks quite thin on the right. So this is what we typically see in a healthier bowel and what we see with inflammation. In addition, we also look for increase in blood flow to the bowel. So normally the bowel should have no blue and red when I put the Doppler mode of the ultrasound machine. There should be none of this blue and red on the wall. I should see blue and red in a vessel because I want to see blood flowing there, but never on the bowel wall itself. And here's an example of the patient who had severe engorgement and blood flow to the bowel. So when you think about this, think about like you're stubbing your toe. It typically will swell, just like the bowel will, and it will get red because there's engorgement and increasing flow to the area. The same goes and happens in the bowel, and we can depict that and describe it and quantify it. We can additionally see mesenteric fat, which was commented, which I was loved hearing about and already know that you're educated about that. You could see it here in those in the image, the background, that white background to the bowel. That's mesenteric fat, and it's a sign of inflammation. We can also see complications such as strictures. So this is a terminal stricture. You could see the wall is thickened and there's a bowing of the bowel wall. And this is essentially, if you imagine a cartoon hose that is narrowed at its end and you turn on the water, it will bow over by trying to push the water through that clogged or narrowed area. And you see this bowing like we see it right here depicted by the yellow arrow. So we could see not only strictures, but also fistulas, these abnormal connection or tunnels that the Crohn's can form between bowel segments and other organs. So we're in the era of treating to a target approach in IBD. And in general, this means that we like to choose some objective measure, as I covered that symptoms don't really depict well what goes on in our bowel. And so we need something objective, whichever target it may be. We will assess for degree of inflammation by either the stool marker or endoscopy or an ultrasound. We start treatment and then we reassess by the same objective measure whether we are achieving a target of response or remission by that parameter. So currently endoscopy, which is our gold standard, is something we could use and look initially for endoscopic inflammation. We will then start treatment, but then we can only reassess for response in order of 6 months or more because patients just it's too difficult to tolerate and insurance coverage can also be limiting. And so that time and cycle is incredibly long. But when you look at intestinal ultrasound, that time frame shrinks significantly. And so when we do intestinal ultrasound, we could really shrink the time between initial treatment, assessment of response, and even assessment of remission. And I'll show you how we do that. So intestinal ultrasound can be used in every part of management from diagnosis. We don't diagnose it solely by intestinal ultrasound, but at the time of diagnosis, we achieve baseline measures of inflammation. We then assess response within 1 to 3 months on treatment initiation. And then even when patients achieve remission, we like to have proactive monitoring to detect those early signs of relapse before patients even feel symptoms. So I've mentioned intestinal ultrasound detects response very early. And this is a beautiful study that depicts this. And this is a study of 242 ulcerative colitis patients from 42 different German IBD centers. And these patients were on various treatments, and they all underwent intestinal ultrasound before starting the study, or at the time of the inception of the study, I should say, 2 weeks after starting treatment, and then 6 weeks and 12 weeks. But what I've circled here for you is you could see that about half of patients within 2 weeks normalized their bowel thickness. And that was on patients that were on various treatments, which means that no matter what you're on, especially in ulcerative colitis, you can see a response very early, within 2 weeks on intestinal ultrasound. And I'm sure if you ask yourself, how often do I typically see my provider? We're typically spaced these assessments in months. And so intestinal ultrasound, again, changes that timeline significantly. Another message I want to deliver here is although intestinal ultrasound is a superb and excellent tool for monitoring, we don't want to abandon any of our other tools. And in fact, when we use that in combination with stool calprotectin, we are even more accurate in detecting inflammation. So the utility of using both in combination is still one great and wonderful for numerous reasons, not only for its accuracy, but sometimes patients can't just come back for another ultrasound in a clinic visit, or they're away and they're on vacation and maybe in a different state, and it can just go to a local lab and get your provider some data if you're unwell. And so that's a big message to take. Intestinal ultrasound can also predict colectomy better than endoscopy, as it really can look at different features of the bowel, not just inflammation of the first layer, but the various layers and the surrounding fat that we've just discussed. And so it has some superior predictive abilities. So I want to finish this segment with a case. This is a 17-year-old boy who presents for a second opinion after being diagnosed with ulcerative colitis a year prior. He presents with three bloody bowel movements a day and three bowel movements at night. He was losing weight, and his stool calprotectin was very elevated. So this is the initial ultrasound images that we see, and you could see this sausage structure cut the long way here, and this is his sigmoid colon. You could see that the walls are incredibly thickened. That Oreo cookie right here is far greater than 3 millimeters. We can appreciate that mesenteric fat, that white surrounding to the bowel. There's a very clear inflammatory reaction. You could see those under Doppler view, engorgement or hyperemia, as we call it. So we start a new treatment, and I have him come back in just 2 months, and we reassess at the time where induction it's all just at its end. And you could see under this window that the wall of the bowel is significantly thinner, almost looks like someone else's bowel. But there is some hyperemia, these little blue and red dots that shouldn't be there. So although I was satisfied, his symptoms improved, his calprotectin improved, I wasn't seeing complete healing, and I wanted that engorgement to go away before I reduce to maintenance dose. And so we kept the maintenance dose a little higher at the same, we kept the induction dose, excuse me, a little longer, and followed up. And you could see that at 6 months, his bowel not only normalized, the engorgement was gone, and he went and did very well. So we have a lot of testimonials, and this is just one from one of my patients. There's a story at University of Chicago where he talks about how every week he would travel to University of Chicago and see his images on the screen. His inflammation would slowly dwindle and dwindle down until it was completely gone. And so this is an incredibly empowering experience for a patient to be able to see what he feels inside. There are a lot of limitations to intestinal ultrasound that I do want to cover. It performs less well than MR and CT in looking at inflammation at the upper parts of the small intestines, like the duodenum, jejunum. And so we need to be careful if you have disease there to intermittently use other modalities. And the same goes for patients who've had multiple surgeries and anatomy is different. We want to alternate with these modalities. Perianal disease could still benefit from MRI imaging, although if you have a provider who knows how to do intestinal ultrasound at the bottom, they could use that intermittently, and I do perform that. We don't diagnose IBD with intestinal ultrasound alone, and we do not screen for colon cancer with intestinal ultrasound alone. Although intestinal ultrasound logically seems like a good screening tool for IBD, it's not yet validated for that. So I want to just shift gears and introduce you in a couple minutes about to the intestinal ultrasound group of the United States and Canada, IUScan. IUScan is the leading organization and authority on intestinal ultrasound training, clinical implementation, research, and education here in North America. We are a nonprofit organization, and we have a website that has not only a lot of information for clinicians, but also a page for patients and resources for patients, including a clinician directory that you can look up clinicians who perform intestinal ultrasound by states. And with that, I want to conclude and just introduce the University of Chicago's intestinal ultrasound program. We were the first program in the country to officially be one that integrate intestinal ultrasound to practice. We have a number of clinicians and fellows who perform it and incredible research coordinators. We offer it in 5 different locations, and there are a number of other locations coming soon. So there is a QR code there if you're near us or interested in coming for intestinal ultrasound or IBD care that includes intestinal ultrasound in it. Thank you very much.
Thank you so much, Dr. Cleveland, for sharing this presentation with us. And now I'm very pleased to introduce our next speaker, Dr. Adam Fay. Dr. Fay is an assistant professor of the Medicine and Population Health at NYU Grossman School of Medicine and director of clinical research at the NYU IBD Center. His work focuses on how factors such as frailty and sarcopenia influence outcomes in older adults living with IBD. Dr. Fay has received funding from the NIH, NIA, the American College of Gastroenterology, and the Crohn's and Colitis Foundation. And he holds several national leadership roles in IBD and aging. He is co-editor of the recent large-scale ACG monograph on geriatrics and GI and has been invited to speak both nationally and internationally on his work. Dr. Fay will be presenting his talk from Congress, Controlling Disease Activity is paramount to prevent disease-related morbidity, making the case for JAK inhibitors. Welcome, Dr. Fay.
Thank you so much, Victoria. Thank you so much to the Crohn's and Colitis Foundation and for everyone. And that was an amazing talk from Dr. Cleveland. So I will try and follow it up with some other highlights from Crohn's and Colitis Congress. So just to kind of set the preface, I will kind of couch this within older adult and aging because that was what the talk I was given. However, much of this applies to all of our patient population with inflammatory bowel disease. And a lot of the research we do doesn't just focus on older adults, but also how we age with this disease and how we age well with it. So even when we're younger. So this part of the Congress was really a back and forth about here's a patient presentation, which I'll tell you about the patient in a moment. And then there was someone who was tasked with kind of giving a pitch for certain therapies. So that was for vedolizumab and for the IL-23s like guselkumab or risankizumab or mirikizumab. And I was given a task of advocating for JAK inhibitors. So we'll talk a little bit about this patient, and then I'll go through how I think about treating patients in general. And then we'll talk a little bit about JAK inhibitors specifically, and then we can be happy to take any questions. So this was actually a patient who developed inflammatory bowel disease later in life. So it was a 67-year-old person. I think they had developed IBD maybe about a year or two prior. It was Crohn's disease. And that can happen. About 15 to 20% of individuals who have IBD actually do develop it later in life. And this person had quite severe Crohn's disease, both in the ileum, so the end part of the small intestine, and in the rectum with strictures. They were put on, I think it was an anti-TNF, I think it was infliximab was the case, and they had been doing very well. They still had some ongoing disease activity, but much better than before. But the issue was that the anti-TNF, the infliximab, was now giving them issues. I think they had drug-induced lupus, so they start to have side effects from the medication. And the question was, what medication should we now switch them to? So this is an older adult. They have a bit of ongoing disease activity. They can't be on a TNF because of this drug-induced lupus. And then they also had some cardiovascular comorbidities as well, meaning like high blood pressure. I think they prior had coronary disease and maybe even had a stent placed. So that was the case. And now we'll talk a little bit about how we approach it. Let's see. Okay, those are my disclosures. Okay, so when I first think about taking care of individuals with inflammatory bowel disease, and when I talk about this with my patients, I really say there's a couple things we aim for, but really first and foremost is clinical remission. We obviously want you to feel well. We want you to go about your day and not have to think about this at all. But there's additional benefit beyond there. And it's really for all adults, but particularly as we get older, this risk to become frail increases. And what is frailty? It's really this state of homeostasis, this balance that can be easily perturbed. And so when we have small insults, whether it's a flare and end up in the hospital, it can lead to larger detriments and adverse effects. And so what do I mean by that? Well, when we talk about ensuring clinical remission, we want to make sure that the patient feels well, right? But there's also additional benefit there. So when you have urgency, what happens? You're not going out much. And I'll show this on the next slide. You're maybe staying close at home. You don't feel like going out and doing daily activities. If you're having pain, so some of those symptoms, that can also interfere or impact what you're eating, and that can lead to maybe malnutrition over time. Also, if you have frequent need for the bathroom or incontinence, again, you may not be going out and getting that physical activity. You may be limited in social and cognitive engagements over time. And as we get older, we know, and I certainly feel this myself, as we get older, the most important thing, and the data really shows this, is that exercise is one of the best things we can do for our overall health. And these things can really limit that. They can limit exercise, they can limit nutrition. And as I just mentioned, again, if we have abdominal pain, those symptoms, it can lead to not eating what we want to be eating and what our bodies need. It can lead to limited physical activity if we have urgency and we need to go to the bathroom. And it can really lead to limited interactions and social engagement. And perhaps as we get older, that can even lead to some cognitive decline. And so all these things can progress us to frailty. So not only do we want to make sure that there's clinical remission, so patients feel well, but there's also additive benefits for here. So the first thing I always talk about is let's get you into clinical remission. And this is kind of how I walk through it, especially as we get older. If you have your like urgency and incontinence, again, you're probably not going out as much. That can lead to physical inactivity. You want to stay home because you want to have a bathroom close by. If you're getting up at night, that can increase your fatigue. It can make you more tired. And what does that do? It even makes physical inactivity even harder, right? You're sitting there, you're not being as active. That can lead to muscle loss. So this is something we've done a lot of research on. We call that kind of sarcopenia, but sarcopenia, as we start to lose muscle, that can also complicate the picture. And then if there's ongoing inflammation, you may need steroids, and that can increase the muscle loss. And then what does that do? As we get weaker or our muscle loss increases, it gets even harder to get out, go about, and do things. We feel more fatigued. We feel tired, right? Even small tasks, which maybe a couple months ago we felt well doing, now we're just very fatigued from even that. And then it can lead to downstream consequences and hospitalizations. So really, we want to make sure that our patients, particularly as we're aging, that we get them into clinical remission so that we don't kind of go through this cycle. What about endoscopic remission? So there's kind of three levels. I talk about, let's get you into clinical remission. Then I want to do endoscopic remission. There's all the data showing that there's additional benefit from that. And that means that we do a colonoscopy or we do one of these endoscopic exams and everything looks healed. And then there's even a deeper level, which is tissue level, which is taking a biopsy, histopathology, and that's all healed. But at the very least, we tried to get endoscopic remission in addition to getting clinical remission. And the reason being because we know that not only if we get you better for clinical remission, but if we can push and make sure that colon and that small intestine all heals, we do decrease the risk of downstream consequences. We decrease the risk of hospitalizations and steroids. And as we get older, hospitalizations and steroids have bigger impacts. And again, this is something that comes up over and over again at all of these conferences, but we have to remember corticosteroids can be great. They're often needed. We need them in short term, but over the long run, there's a reason we use corticosteroid sparing therapies. We want to get off prednisone because long-term risk is high. They really are associated with the highest cumulative risk. That doesn't mean don't use them ever. We use them frequently and often when we need to, but we really try to minimize them and do the shortest duration. So there's additional benefit with pushing into endoscopic remission, and we actually looked at this in the older adult patient population. And what we found is not only do if you achieve clinical remission, but even if we took older adults with IBD had mild endoscopic disease, so not much, versus endoscopically healed, normal, we actually found that there was an improvement in outcomes if we were able to fully heal those individuals. And so at 1 in 5 years, there were lower morbidity, so collecting of comorbidity, other complications from it. There were fewer hospitalizations, fewer need from steroids. So there are individual tailored approaches. So this isn't, one size fits all, but as much as possible, we really try to push into endoscopic remission. So again, getting back to this case, now we make the case for, okay, this patient may be or maybe not in clinical remission. They weren't in endoscopic remission. So the last time someone did a colonoscopy, they still had active disease. We were making a switch and they wanted to talk about JAK inhibitors, so upadacitinib, which the brand name is Rinvoq, which you may have heard of. There are other JAK inhibitors like tofacitinib, which we don't use for Crohn's disease. We really use for ulcerative colitis, and that's Xeljanz as the brand name. When you look at the efficacy in the trials, so these are folks, I pulled out the data who had failed or had an adverse outcome from TNF, so infliximab, meaning that maybe they had a side effect or it just didn't work for them. What you can see is for those individuals with Crohn's disease who were put on upadacitinib, about 55%, so about half at week 52 had a response. Now, this is of individuals who already had a response in the initial trial period. So when they design trials, there's an induction period, which is those couple few weeks where you get a higher dose, and then there's the maintenance period. So this is the maintenance study. So this is only of the people who responded to the drug in the first part, how many would respond later on. So of the people who already responded early on, about 50% were in clinical remission. So that's good. Again, we want to achieve clinical remission. When you look at endoscopic remission, so again, we want to make sure we're healing on colonoscopy, about a quarter of those. Now, this is hard to achieve sometimes, full endoscopic healing, especially in individuals who have already been exposed to certain therapies. That can be a little bit more challenging. And you may say, okay, but you said this is essentially only for people who responded to the drug. What percentage of individuals responded to the drug? So you can see here, this is that initial induction period, and about half, so about 53% of individuals who were already exposed to prior biologics actually responded to this medication. And what you also see is that time to response is pretty quick with JAK inhibitors. So by 2 weeks, 33% responded. By 4 weeks, 46% responded. And again, if we think about the urgency and staying home and the needing prednisone and fatigue, these are things that we want to be on top of. We want to really get the patient and get them feeling better quickly. So if we have to wait 8 or 12 or 16 or 20 weeks, that's time when they become malnourished or they're losing muscle mass and they can become frail. So a quick time of onset when we're thinking about treatment modalities, which medication or surgery should we really be thinking about? That's very important to us as well, and obviously to all of our patients. What about side effects? So this comes up a lot. What are the side effects with JAK inhibitors? So there was a big study in the rheumatoid arthritis population, which showed that older adults may be at higher risk for blood clots, cardiovascular events, maybe certain types of cancers. The overall risk is fairly low. But what happens is when we look at this within the IBD patient population, we're not seeing it quite as much as the rheumatoid arthritis population. There's a couple potential different reasons for that, but this was one recent nice study that actually looked at this. So they took claims data. That just means from insurance data where we have all of the codes and we know who's on what medication. And they followed patients who either were on JAK inhibitors with inflammatory bowel disease or TNF antagonists. So that's your adalimumab or Humira is the brand name, or infliximab or Remicade or Renflexis. You may have heard some of these. And they compared the two and they said, well, what's the risk of infections, blood clots, and cardiovascular events? And what they found was infections were pretty similar, but what they found was overall slightly higher risk for those JAK inhibitors. And we do know it does increase the risk of shingles. So certainly if you're on that medication, getting the shingles vaccine is very reasonable and should be done. When you look at blood clots, very similar incidence rate. Incidence rate out of 100 person years just means how many times did you actually see someone get a new blood clot out of 100 person years. So if you followed 100 people for 1 year, that's 100 person years. So it was only about one person, right, within each group, and pretty similar. And same with major cardiovascular events, very low. Now you may say, well, were these younger patients? Were they older patients? Are these older patients with cardiac comorbidities? How do I know about my risk? Well, when they looked at that and they pulled it out and they said, well, we know in that prior study of rheumatoid arthritis, it was older patients, smokers, these potentially had higher risk. What if we look at a similar population here? And it was actually pretty low incidence of cardiovascular events. You could see only 0.4 versus 2.1 within the TNF group out of 100 person years. So overall, it's a fairly low risk. It's still something we counsel and I talk about with my patients. And each individual has their own risk profile. So just because someone might be lower risk doesn't mean another person's not higher risk. It does need to be discussed and kind of gone over. But overall, the data has looked okay so far for it. Now, the patient in this example in the Crohn's and Colitis Congress had prior coronary disease and stents. So if you tried to apply that here, only 2% of this cohort had prior coronary disease. So again, these need to be individualized decisions. We do need more data here with this. So let me just sum up with some quick take-home points, and then we can open up for Q&A. So hopefully we've chatted about why getting into clinical and endoscopic remission can improve outcomes, not only for all patients, but again, particularly in our older adults as we're starting to think about aging and the impact that that can have. We do use them, but we really try to limit the need for steroids as possible, has the highest risk of adverse outcomes. And achieving clinical and endoscopic remission can limit adverse events. We have to remember, we talk a lot about medication and safety and things, but we have to think about the flip side, which is that ongoing inflammation itself is a major driver of adverse outcomes. So we really want to make sure that we're adequately controlling the inflammation. It reduces the risk of needing steroids, of hospitalization, surgery, and so forth. It also allows us diet liberalization, right? You're not going to get malnourished. You can engage physically, cognitively, socially, improved overall quality of life, and it reduces that overall progression towards frailty. So then we switched to talk about JAK inhibitors. In this case, it was upadacitinib, and we showed that it can be effective, not for everyone, but at least it does have some efficacy within Crohn's disease that we can see even within those who are bioexposed, meaning they've been on other biologics or other medications in which it can be harder to treat. I didn't show it here, but in the talk, we also talked about how it can work in ulcer disease. Well, there were ulcers in this patient in the terminal ileum, and there's some good data that it can work with ulcers as well. And the patient in the prompt had ileocolonic disease, which upadacitinib has shown efficacy for as well. That's disease both in the small intestine and the large intestine. And then we did talk about how we do need additional data, but the overall risk with these medications do appear low, even among an older cohort who are enriched for cardiac comorbidities, so high blood pressure, cardiac disease, things like that. But we do need longer term data, and we do need to have these individual decisions because some individuals are at higher risk for this. And particularly as we age and develop comorbidities, we need to be thinking about this. But regardless, again, whatever therapy we were going to pick within that talk, again, there were multiple therapies presented. It's really about timely initiation, so not letting time go on where we're getting malnourished and becoming frail, close follow-up. And then beyond that, I think one of the keys to take home is most often the most efficacious choice of therapy. So the thing that's going to get you feeling better and heal the disease endoscopically turns out to actually be the safest one. It keeps you out of the hospital, keeps you without infections, and so forth. At the bottom right, this is the monograph that we just published on geriatrics and GI, if anyone's interested. We also have a website. If anyone is interested, it is still in progress, so we'll have more in there soon. But we have a lot of research and a lot of our publications are within there as well, and resources for patients called IBD over 60. And then last, I'd like to end on this quote, which is, to care for those who once cared for us is one of the highest honors, which is in part why I'm so passionate about some of this aging work and its conjunction with inflammatory bowel disease. And then on the right was one of the prior Scandinavian conferences I was speaking at, and we took our daughter to the Ice Hotel north of Sweden, which is amazing if anyone's been. And I will stop there. So thank you again.
Thank you, Dr. Fay. And now let's bring all our presenters back and we can take some questions from our audience. If you have a question for one of our panelists, please type it in the Q&A box, which can be found at the lower part of your screen. We already have some questions rolling in, so I'm going to jump right into it. The first question is for Dr. Cleveland. Dr. Cleveland, could intestinal ultrasound eventually use AI to potentially produce a 3D image with even greater diagnostic utility?
I believe it will. It's just a matter of time. We are working very hard, and there are numerous groups who are working with different AI companies and platforms in order to develop AI utility of intestinal ultrasound. There are different ways to utilize it. So there is a way to um, read an image that is already acquired by a sonographer, and there is interpretation that um, is beyond measuring the bowel wall itself. So there are already AI tools developed by one of our ultrasound manufacturers where you would take an image or select an image of a bowel, and it would measure the walls for you with incredible accuracy, about 100 measurements in a very small area. So you can imagine that'll give more accuracies to the true bowel wall layer. And the various layers, which we typically don't even go into nuances of those. So in short, there's already integration, but not to the extent that we need it, but it's in process. And I think in 5 years or so, I think we will see it rolling regularly in clinical practice.
Thank you, Dr. Cleveland. And let's see, we have another question here for Dr. Fay. Dr. Fay, do you foresee a future where insurance providers in the US might allow, and please excuse me, we're going to try to navigate the pronunciation of this medication. Um,
Upadacitinib.
you
Yeah.
got it right on
All
the
right.
money without trying a TNF blocker first. Thank you for your
Yeah.
assistance on that.
No, of course. And I was typing an answer, and someone asked for the website, and I think I messed something up, so I put it within there as well. Yes, so the FDA actually has recently changed their guidance on um, or their wording per se about how so upadacitinib months ago, Rinvoq is the brand name, could only be used after you really fail a TNF or if you had a true absolute contraindication, like there was some reason you really couldn't use the med. And now they've kind of softened their language to say, well, if there's another reason or something suggestive, you could use it generally after you've at least tried one other medication. So what we're seeing and what I'm doing as well, is really positioning it a bit earlier within some cases. So if there's a good reason to be using upadacitinib, you think it's going to have good efficacy, rather than have to jump through the hoops of, well, I need to do this and I need to try a TNF first and then show that they fail, we will just essentially push it forward. And I think insurance and things, everyone's getting behind that modality and it's getting easier and easier to use in that sense.
Thank you, Dr. Fay.
Of course.
Here's another question for Dr. Cleveland. What is the cost of the ultrasound, and is it usually covered by insurance?
So, intestinal ultrasound is most of the time covered by insurance without requiring prior authorization. That being said, there are a few states where that won't, that would still require prior authorization, but the vast majority don't, which allows us to use it as a point of care test where I don't have to get prior approval. Because if we did that, it will be similar to the delay that happens with other radiographic images. So, in our practice, we've ran almost every insurance, and there was no need for prior authorization. This is actually billed as a limited abdominal ultrasound, similar to what you would order for a kidney stone or looking at your liver or your gallbladder. So typically it's covered, and it's a fairly cheap exam compared to CT and MR and others.
Thank you, Dr. Cleveland. Dr. Fay, can you please speak to the cancer risk of TNF blockers versus JAK inhibitors?
Yeah, absolutely. I mean, we do see potential malignancy risk with TNF inhibitors and JAK inhibitors. There's two different storylines. One is relative risk, which means what is the risk relative to something else. So, for instance, you may hear this gives you three times the risk of cancer. You may say that sounds horrible. But when you look at the absolute numbers, it may be 1 in 10,000 people get cancer without the drug, and maybe 3 in 10,000 get it with the drug. So although it is a three times increase in the relative risk, it's still pretty small. And we actually are going to have hopefully a publication coming out on this in one of our journals, the American Journal of Gastroenterology, where we talk about these risks a little bit more so you can understand the absolute risk. So they do seem to be there, but they're small. And so it really then becomes a conversation. What's your family history? Do you have a high family history risk of these cancers? Have you had these prior cancers before? What is your disease burden? Is this really the best medication for the disease person? Because if it is, and the absolute risk of getting one of those cancers is small, it's still likely makes sense to have that medication. And especially with TNFs, and we think about skin cancers and melanoma, we talk about going to the dermatologist once a year and getting a skin preventative checkup. So there are ways to kind of mitigate those risks as well. So this is kind of the discussion about how individualized the approach needs to be. But yes, it does seem like overall there is a bit of a risk. But again, the absolute risk, so the actual number getting it, seems to be fairly small with both meds.
Thank you, Dr. Fay. And I have a follow-up question.
Sure.
Does the medication you spoke about, do they heal fissures at all?
Yeah, so there is some data to suggest that upadacitinib JAK inhibitors can heal fistulizing disease. Fistulizing disease can be very challenging to heal. Still, TNF tends to be the therapy that we reach for most often in first line. But in the absence, or if you can't use anti-TNF or it hasn't worked in the past, there can be some efficacy from JAK inhibitors and some of the other medications as well. So yes.
Okay, and Dr. Fay, one more. Do
Sure.
you foresee a future where insurance providers in the U.S. might allow upadacitinib without trying a TNF blocker?
Yes, yes, I think so. Now that the FDA has kind of updated their guidance and it's a little bit softened that wording, I think we are seeing it and we are using it in that way and we are getting it approved. So I do think this will be more and more. Absolutely.
Fantastic. Dr. Cleveland, we've had a few questions come in. Can you remind our audience, how do we find doctors who use intestinal ultrasound?
Yes, so you can go to IUScan's website. It's iuscan.org, and you could find a clinician directory that you can search by state and identify clinicians that perform intestinal ultrasound. Right now, there's a designation of whether they have had uh, certification by the International Bowel Ultrasound Group or not. Typically, those who uh, have completed a training, it would translate to at least having some sort of a curriculum that is uh, vetted, but um, it doesn't always speak to competency. So you would have to look clinician by clinician in terms of whoever is in your area, and then inquire with them whether they're. I imagine that if they're listed in our directory, that they're seeing patients who perform it. We actually vet anyone who is on there, and so you should be able to get an intestinal ultrasound exam that is done by one of those clinicians and feel comfortable with it.
Thank you, Dr. Cleveland. I have another question for you. Does anything improve the quality of intestinal ultrasound? For example, conducting the ultrasound while the patient is actively having symptoms.
Um, it's a good question. I don't like to kind of burden patients with trying to make the exam better or worse. The beauty of it is that you can come however you'd like after your lunch, before your lunch, and don't worry about it. I actually, it's true that when you have inflammation, the bowel is thicker and it's easier to identify, as you saw in the images. But when we talk about improving quality of images, we typically think about other things. So BMI can sometimes play a role if a patient has a very high BMI or a very large central, like obesity or a large belly. Sometimes the bowel could be really deep and we have a hard time identifying it. But there is no true rule to BMI. I scan every patient with almost every BMI. I never ruled out a patient based on BMI, and that will vary. Sometimes I could see everything I need, even at higher BMIs. But it's true that the thinner patients, the pediatric patients, the bowel wall and the abdominal wall is so thin, you could see the bowel so clearly through. Another case where we have a hard time seeing is patients who are pregnant, very advanced. From 26 weeks and on, the uterus is large and it obscures part of the bowel. But we still utilize an earlier stage of pregnancy up until then very well, given it's the wonderful benefits of it without being radiation, etc. I do like when patients eat a little bit before they come because I like when the bowel is awake and moving. Patients who have fasted all night and come to clinic without anything, sometimes the bowel is just kind of sleepy, and but it's not a must. You don't have to do it.
Thank you, Dr. Cleveland. Um, can intestinal ultrasound show inflammation that's more in the rectum?
Um, Also a very good question because intestinal ultrasound is an excellent tool to detect inflammation throughout the colon. The rectum, though, is such a deep structure that the sensitivity of detecting inflammation drops quite a bit from the high 90s to 70. And when you undergo ultrasound, you'll be able to see the image yourself. It's quite different because we look at the rectum through the bladder. So the sensitivity of detecting inflammation in the rectum is a little low when we look through the abdomen. But some of the people who have been trained in intestinal ultrasound have some training in perineal ultrasound, which where we place the ultrasound transducer on the perineum. It doesn't go inside the rectum or any orifice, it's just on the perineum. But then we see the rectum with almost 100% sensitivity. And that is an incredibly accurate way to see the rectum. So when I want to see the rectum with such sensitivity and I'm really need to know exactly what's going on in the rectum, I will use a transperineal approach.
Thank you, Dr. Cleveland. This is going to be our last question, and it is for Dr. Fay. Dr. Fay, does upadacitinib carry
Hi.
the risk of building antibodies to
Ah,
yes,
yes.
carry the risk of building antibodies if one stops taking it and needs to switch to different treatments and then return to it, for example, insurance reasons. Someone has heard that this is the case for some treatments.
Yes, great question. It is for some treatments. Mostly it's the anti-TNF treatments, not for our small molecule inhibitors. So essentially, biologics can. It's really the anti-TNFs, but small molecule inhibitors, no. So there's no antibody. So if you do stop it for whatever reason needed to occur, there should be no antibodies to develop. And in fact, if you look at the efficacy, so how well it works after you stop it and then restart it. Now, it can not work after that. So we really, if we're doing well and there's no side effects and it's controlling the disease, definitely stay on the medication, have that conversation with your doctor. But it does have a high recapture rate, meaning if there was an insurance glitch or something and you left it at home for a week or two and then you started having a little flare and you restarted it, two-thirds, if not more, will get recaptured. So there is a good recapture rate, no antibodies. So in that sense, it's a good agent.
Thank you, Dr. Fay. And
Of
thank you
course.
all. This was a great discussion, and we learned some helpful information today.
Great. So our program is coming to an end, and this is all the time we have for today. On behalf of the Crohn's and Colitis Foundation and the AGA, we encourage you to keep learning about IBD and to visit some of our helpful educational resources. I want to remind everyone to please fill out the evaluation survey that will be sent to you after tonight's program. We really appreciate the feedback, and it will help us plan for future programming. So thank you, everybody. Thank you for joining the IBD Insider Patient Education Program and have a great rest of your evening.